I'm Dr. David Gross, psychiatrist.
I'm Dr. Andrew Rosen, psychologist.
And we are two shrinks and a mic. Today we're going to talk about what we're calling Therapist Confidential. Basically talking about some of the issues we raised last time, which is that in many respects, the field of mental health is a bit of a landmine in that, as we said last time, if you're going to go see an internist, a primary care doctor, you have some idea as to what they do. But for the most part, whether it be psychiatrists or therapists, psychologists, master's level therapists, I think the public has very little understanding as to what they do. In fact, when you go to council meetings in various towns where they bring up mental health issues, oftentimes the counselors there, the council people, are not aware of the difference between a psychiatrist and psychologist. And so the general public really doesn't know exactly who we are and what we do, which makes it a problem in terms of picking a therapist. And we're going to talk today about some of the difficulties and some of the trade secrets, so to speak, in our field.
Thanks. In terms of trade secrets, I think we're going to go a little bit to the towards the end of the continuum in terms of revealing and acknowledging some of the things that people over the years have thought of mental health professionals. It's not unheard of for people to say, well, all you shrinks are kind of crazy to begin with, or I wouldn't want to be the child of a shrink because they seem to be the most messed up. And obviously that's kind of just an exaggeration in most cases, but the truth of the matter is that a lot of people go into the field of mental health for the goal of not only helping other people, but for trying to help themselves, an awareness of, I have things that disturb me and bother me, or things that I've been through, and maybe I understand it better so that I can help other people while I'm helping myself. An example of it really becomes more obvious in the rehabilitation community, in the drug rehab community, or alcohol rehab community, where in most treatment centers, the people who are doing the treatment are actually people who have been in recovery. So it's not unusual to have clinicians, whether they be psychiatrists, psychologists, social workers, mental health counselors, et cetera, having had a history of their own issues and their own problems. And that could be a good thing in certain respects, but it could also be a bad thing if the issues that the clinician that you're having to see, the issues hopefully are resolved. It does mean that it's not typical that you see somebody who has overt problems, but one needs to consider that the mental health professional is not this person of perfection who has no issues, and it's important to just acknowledge that.
I think it's helpful to talk about some of the basics to begin with. You want to make sure that your mental health clinician is licensed in the state that they're practicing. And getting licensed in that state requires passing requirements in terms of training. You have to be at a credentialed treatment therapy program in graduate school or medical school, and then psychiatric residency program. But then you have to take a license exam and pass it. That then gives you the right to put up a shingle and practice. Mental health professionals who then decide to be insurance providers have to then get credentialed by the insurance company, which requires providing the company with information about training, licensure. Sometimes it requires you provide evidence of malpractice insurance, and then you can get credentialed by the insurance company. In the state of Florida, where we practice, for example, you can't practice if you have a master's level degree in psychology. Many other states you can. In Florida, you need to have either a social work degree and be licensed, a mental health degree and be licensed, marriage and family therapy, and a PhD or a PsyD. The PsyD programs are a relatively new development in mental health because they're clinically oriented. The PhD programs require research and a thesis, and they're more geared towards academia. But the PsyD programs are a bit shorter, but they're really more clinically oriented. In this day and age, most of the psychologists I've seen, at least in Florida, graduate from PsyD programs. So getting a license levels the playing field to some degree, but then after that, it's a little bit of the Wild West. And the reason I say that is that the book learning in master's level programs or doctoral level programs or psychiatric residency programs are all going to be similar. They're credentialing bodies that require these programs to have a curriculum that meets their expectations. So the book learning is going to be about the same. But how that person then takes that learning and applies it out in the field can be totally different. And an example of that is if somebody decides they want to learn a technique of therapy called dialectical behavior therapy that was originally developed for borderline personality disorder, they may then turn around and apply it to everybody. One size fits all, and that's something we've talked about before, and that could be a real problem. So in many respects, part of the theme that we're going to be raising today is the concept of holistic mental health care, the fact that you need to see the entire picture and not just hone in on one area and apply the treatment that you're well versed in.
All of the disciplines that you just mentioned, Dave, in the state of Florida, to call yourself a psychiatrist or a psychologist or mental health counselor, you have to have graduated from a program that is documented and approved and certified, and then you have to be able to pass the licensing exam of that state. But historically, it didn't always work that way. I remember years ago I attended in New York City it was called the Lefkowitz hearings, and this was at a time where there was very little legal control over the mental health disciplines, and many people would call themselves a psychotherapist. But there is no license or actual training for the title psychotherapist. It was a way for people to say that they were mental health professionals, but they weren't. They would just call themselves a psychotherapist, and nobody could say anything about it. They'd put their name and their degree in the yellow pages, and then the unsuspecting person who was looking for help would go to that quote-unquote psychotherapist. Now, you don't find too many people using that title, but the new title that's out there quite a bit is the life coach. Now, a life coach is somebody who has no experience, no training, no formal training, and there's no license, but they've decided to help people, and they call themselves a life coach, and it's really caught on a lot in social media, and there's actually some fairly well-known life coaches, and not to say that all of them don't help, but when people go to see a life coach, it may be somebody who just needs a little life coaching, whatever that might be. It might be about career. It might be about something related to motivation. But it also may mean that somebody who really has a bunch of serious problems might end up with the life coach and actually not only not get help, but actually be mistreated. So it's very important to go back to look for a person who is licensed in one of those disciplines and then has gone on for more training, because when you graduate any program, you know very little. You know the basics. It would be like going to a physician or a surgeon who just graduated and just maybe hadn't seen their first patient yet. You wouldn't do that. You want somebody with experience and somebody who has documented evidence that they've been through different kinds of training programs. Same thing in mental health. So you can find that information, and if they don't have any documented advanced training and fellowships or ongoing training in a particular area like anxiety or depression, etc., then best to stay away and find somebody who has more training.
I don't know if I told you this, Andy, but when I first came to Florida many moons ago to go to medical school at the University of Florida, I found out, to my surprise, that at that time in the state of Florida, the only thing that you needed to be able to say that you're a licensed therapist was to have a diploma from school. So I knew of a psychiatrist in Gainesville who had his public school diploma on his wall, and that's what qualified him for it. That changed pretty quickly after that, and Florida then developed pretty strict guidelines for licensure in the state of Florida. Now it's not easy to get a license at all. In psychiatry, besides getting a medical degree from a medical school that's a certified medical school, you need to go for a residency training program that's certified. You also have the option to get board certified, which requires special testing. And I know that they have that in psychology as
Right.
well to become a diplomat. And many insurance companies and many other organizations that hire mental health professionals, psychiatrists, require the board certification. I'm not sure it made me a smarter psychiatrist or a better psychiatrist, but it's a hurdle to jump through. If you're seeing somebody who's not board certified, it doesn't mean that they're an inferior psychiatrist. May mean that they didn't think it was important, or it may mean that they had trouble taking the test, and those tests were pretty difficult.
I think it means that you're finding somebody who wanted to sharpen their pencil as much as they could, somebody who wanted to learn more, demonstrate more, stay with the learning process, and actually document it. It doesn't mean that they actually are better at what they do, but it does demonstrate somebody who's really serious about being the best they can be.
And then that raises the question as to how do you know somebody is good? I mean, now everybody gets on Google and looks at Google reviews, and they help some. You know, they will talk about the front staff, and they'll talk about how comprehensive the individual is, and it helps to look at that. It's interesting. I have a website, and I have articles I've written on the website, but the number one item on my website that people tell me about gave them the most confidence in calling me for the first time was a video I did with a psychologist in town where we were talking about depression. He was interviewing me because it was his video program. And there they got a chance to see who I was and how I sounded. And I think that's the difficulty. A lot of individuals now will go see their new primary care provider and they'll go for a meet and greet meeting, which makes a lot of sense. You know, the physician needs to know that this is going to be a good match. And I think it's most important that the patient knows that this physician is somebody who's okay for them. And that's the same thing in mental health. It's nothing wrong with meeting with your prospective mental health provider a few times to get a sense of who they are and what they're like. I mean, if the first time you sit down with your mental health professional and start talking about all the problems in their own lives, you've got an issue there. And unfortunately, that's much more common than people realize.
Oh,
And
yes.
I'm not sure what motivates that. I think a lot of the times mental health professionals lose the luster and lose the spark they have and use the therapy session as an opportunity to ventilate themselves, which is totally inappropriate and unethical, and it's not part of the guidelines for either psychiatry, psychology, or social work, or any of the other master's level mental health disciplines. But sit down with that individual and get a sense of who they are. In addition to that, you can get a sense of how comprehensive the initial evaluation is. I mean, I've been impressed over the years, because both of us have been around for a long time, that people that you meet with and people that I meet with will come away and say, that was the most comprehensive set of questions that I've had before. In psychiatry, psychiatrists will often stop at the first complaint, which was I'm depressed, and immediately conclude after that what's needed is an antidepressant medication, rather than getting the entire picture. And the entire picture has to include, the medical information, which we call the biological, a sense of where that person comes from in their childhood that helped modulate and mold their psychological mechanisms, good and bad, as well as the life context they live in now. What's the social situation they live in? Are they in a good social support system, or are they isolated? They have a job that they're happy with, et cetera. So finding, when you sit down with that individual and you get a sense that they're covering all the bases, then you're in a good office. But if it looks like it's just focused on one area, which may be the area of expertise and interest that person has, then you've got a problem. And we see that, both of us, in the drug rehab industry, where clinicians who are rehab specialists will hone in on the drug issue and the drug history rather than getting the whole comprehensive history that they need to get.
Yeah, you just reminded me of a line in a movie. I can't recall the name of the movie, but it was a line. It was somebody who was pretty narcissistic who said, "All right, enough about me. Now let's you talk about me." And when you see a clinician who seems to be eager to talk about themselves, then I think you can pretty be sure that you're in the wrong place.
That reminds me of a clinician in town whose chair was elevated higher than the other chairs in the office.
That'll show them. But there's a lot of that going on, whether it be just verbally talking about something of their own experiences, presumably to get the patient to really feel like you understand me. Or even I know there's people who put personal information on the websites and on social media about their day-to-day life and the problems they have. And again, presumably to demonstrate, I understand you and here's what I did to help myself. But in general, I don't think that's what motivates it. I think what motivates a lot of self-disclosure from clinicians is they have the need to be heard as well. And maybe nobody's hearing them, so now they have a good audience. Patients who want to be connected, they want to have a relationship with their therapist, and now they have somebody to relate to. So it's always been frowned upon to do self-disclosure. Certainly once in a while, a clinician, you, me, or anybody will have some self-disclosure, for maybe superficial reasons like, your car or where your office is or something like that. But we've always been trained to keep as much of a blank screen as possible and not make it about us. But when you see a clinician who's making it about them as well, or even 50-50, then it's just inappropriate and to be frowned upon.
You're raising a very important issue, which I've been aware of ever since I got into this field, which is the power that the mental health clinician has in the consulting room, the power they have over the individual they're consulting with, because the patient, the individual comes in for treatment, again, like I said, is not sure exactly what's going to happen, and the therapist, the psychiatrist, psychologist is the one who has all the answers supposedly, and you've got a captive audience in that consulting room, and that can be a problem. I found over the years that the more that people can see me as a real person without having boundary issues and talking about personal things is important. There'll be some things that I will share, like when I've had the birth of a grandchild, which was a wonderful event. Patients enjoyed that information being shared, but to sit in the office and talk about your marital problems or the difficulties you had the other day with some kind of incident is totally inappropriate. But the power there is tremendous, and I think the important thing is for mental health professionals to respect the presence of that power. That oftentimes the individual who's sitting in the patient's chair is feeling somewhat helpless and dependent, and how we influence them can be very good, but it also can be very, very bad. There had been issues in mental health care for a long time of inappropriate sexual boundaries in the therapy office, and that has been an issue. And for some people, there have also been problems with inappropriate business arrangements made in the therapy room. So the concept of power is really very, very important and needs to be recognized. And people who come in for treatment needs to recognize that they have power as well, that they don't have to be passive, and they have a decision whether or not this individual they're sitting with can be helpful for them going forward.
I think it's always important. What we've done is to communicate that this is a collaborative effort to help whatever the issues are that person has. It's not a power struggle. It's not a power play. And just because I'm the one with the training and the experience and you're coming to me for help, should never be exploited. And sometimes that exploitation is really a malignant exploitation where and we've heard stories, whether it be people famous or not, where because of the power of the clinician and the nature of the relationship, one person being in a situation with problems and the other one presumably, the clinician presumably in a position of tranquility and life under control, sometimes that inequality is really, really taken advantage of by clinicians. And sometimes they're very conscious of it, and sometimes it's for money. And sometimes it's to get patients to never leave and to, come in every day and so on and so forth, even when it's not indicated. So not to make it seem like such a bad possibility when you go to see a clinician, I think it's just really important to realize that just like any field, just like any part of life, there's always a certain segment of it that may not be up to par, and we need to be aware of it. And whether it's in our religious institutions, or it's in our medical institution or legal institution, or anything, there's always something to watch out for. And we're just trying to give you the heads up on some of those things. But overall, mental health treatment is a really, really good thing and very helpful. And we have all kinds of personal and anecdotal examples that we feel good about in terms of our ability to help people. And there's lots and lots of well-intentioned, good, well-trained clinicians out there. You just need to know what to look for.
After that initial evaluation session, whether it's 1 meeting, 2 meetings, 3 meetings, 4 meetings, or even more, because sometimes it takes time to figure out what's going on, it's then very important to have a sense of what the goals are. What are you targeting the treatment at? And those targets can change over time. So it may be that, in your talking therapy, the initial goal was to deal with marital issues. But after that, there may be other issues that are present. That is, what are some of the psychological factors that led to the marital problems in the first place in yourself as a spouse that can then get worked on. So coming up with initial, more immediate goals. You and I tend to see people who are in crisis and they have an acute situation. So oftentimes we have to focus on the crisis issue. But after that, we typically will then focus on some of the core issues. And a good example of that is when I'll see somebody with panic disorder and severe anxiety that you're going to be working with as well. Both of us know that continuing with cognitive behavioral therapy will be important, but you can't really do much effective cognitive behavioral therapy unless the anxiety level is somewhat lowered and the panic attacks are stopping and the person's able to comply with the recommendations that you'll make for cognitive behavioral therapy and practice the techniques. And so that's where stepping in with medication can be very, very important, as well as education, because part of our role in the beginning is to decrease the individual's fear that they're crazy, that I really must be inferior and out of my mind and something seriously is wrong, to help them understand what the nature of the problem is, the fact that they can get better and this is what they need to do to get better. And so coming up with a set of goals is really important. But, one of the things that I've heard, and I'm sure you have as well, repeatedly from individuals who have had therapists in the area that they've worked with for a long time, they'll say to me, I'm not exactly sure what's going on anymore because it's almost like this person's my friend and we're just talking about what's happening in life, rather than working on some of the issues. And that's why it's important, I think, in any kind of therapy environment to huddle again and kind of reboot the process and begin to question, what do we have to work on next? And if we don't have a whole lot to work on, then maybe we'll touch base much less frequently and maybe not need to touch base at all. I tell people frequently when their a single episode of depression is gone and they've recovered and they no longer need to be on medication, it says, I'll keep my door open, but there's no need for you to come back to see me anymore. So viewing treatment as an ongoing dynamic process where you always have to reevaluate what the goals are and where you're heading and what's the plan is very, very important.
I always tell my patients, one way or another, my goal is to get you to the point where you don't need to see me anymore. It'll go from need to see me to more of an option to see me and maybe at some point intermittently see me. But my goal is to get you to be freestanding, independent, have a new, as I call it, operating system so that you can go do life in a more happy, genuine, tranquil way. But it's never the intention to just form the kind of therapeutic relationship where it's forever. Now, there are some people who do see me for many years, and it's more a situation of maintaining their tranquility and harmony in life. And sometimes it's new situations come up that are challenging the well-being of the person. But for the most part, it's to get you to, as one of our clinicians says, to get you to fire me, to not need me any longer. And part of that's because we do good work, and so we are very busy. We don't need to, like some people, need to hold on to patients, believe it or not. Thank God we don't need to do that because we do good work. And even in our office, everybody has that kind of experience where they do good work and people move on. And that's the way it should be.
We've talking about the power of the consulting room and firing your therapist. That power itself gets individuals to come in for treatment to feel beholden on the clinician, the therapist who they're working with. And even though they feel like they're just spending money and spinning their wheels and getting nowhere with the therapy, they feel uncomfortable saying, I don't know that you can be helpful for me anymore, or even questioning what's the role of therapy at this point and what are the goals we want to shoot for. So that power itself creates a bit of a paradigm where there's an unequal dependence and it has to be recognized. And at the end of the day, the mental health field is a money-making field. I mean, it's a job like any other job, and there are therapists out there who I'm sure recognize that somebody who stays with them for a long time, it's almost like having an annuity. But it's always reasonable to question where you're at in therapy and where we're going and what's the goal to move forward. It's hard, and I've often had to advise individuals come in to see me who had concerns about what's the purpose of therapy to sit down with their therapist and say, let's do a recap on where we've come and let's talk about where we need to go in a very objective, positive way. And that could be difficult. But as we've talked before, therapy work and psychiatry, for the most part, is subjective. I mean, we rely upon the words that are being said as the patient relies upon the words that we say. So it's not an easy process, but at the same time, I'm hoping that this discussion is helpful for all of you, even though it's some of this is not comfortable to talk about, but it's the reality of the mental health scene. And I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and this has been Two Shrinks and a Mic.
Bye-bye.
Bye. The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.